Our key takeaway is that a one-size-fits-all approach needs to be carefully considered when applying standard heart failure therapies to patients with Fontan. My name is Cyrus Narayan, and I'm an internal medicine resident at the Mayo Clinic in Rochester, Minnesota. I'm going to be discussing our article titled Afterload Reduction in the Fontan Patient, Does One Size Fit All?, which will appear in Mayo Clinic Proceedings in April 2026. We present the case of a patient in his 30s with hypoplastic left heart syndrome, status post-Norwood, bidirectional Glenn, and fenestrated lateral tunnel Fontan on chronic spironolactone and furosemide, who presented with acute worsening of chronic kidney disease shortly after initiation of valsartan. His creatinine went from a baseline of about 1.5 to 6.3 on admission. Workup with transthoracic echocardiography demonstrated holodiastolic abdominal aortic flow reversal without aortic regurgitation or residual shunting. We felt that this was consistent with profound systemic vasodilation. Given concern that valsartan exacerbated underlying cirrhosis-related vasoplegia and triggered renal hypoperfusion, valsartan was discontinued. Renal function returned to baseline within a few days, and spironolactone and diuretics were cautiously resumed without recurrent kidney injury. This case underscores the potential hazards of routine afterload reducing therapy in Fontan patients. These patients typically have a baseline vasodilatory state in the setting of cirrhosis from long-standing elevated central venous pressures. This is because the Fontan procedure reroutes systemic venous circulation directly to the pulmonary arteries, so these patients have elevated central venous pressure to help drive flow through the Fontan circuit, which results in cirrhosis over time. Additionally, we highlight that holodiastolic aortic flow reversal and the absence of significant neo-aorta regurgitation may be a useful indicator of excessive vasodilation in this patient population. Patients with Fontan physiology need careful individualization of guideline-directed medical therapy and close hemodynamic monitoring to avoid precipitating circulatory collapse. It may be reasonable to refer these patients to an experienced adult congenital heart disease center for management. Overall, because data on guideline-directed medical therapy in patients with Fontan physiology is currently limited, future studies or expert consensus are needed to determine the optimal guideline-directed medical therapy regimens in these patients. We invite you to read our article in the upcoming April 2026 Mayo Clinic Proceedings to learn more.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.